Yep. So, welcome everyone to the Health Scrutiny Committee. Before I start the substantive items of the agenda, just to thank everyone who came to the briefings yesterday about the Newark Hospital and Treatment Centre. We'll cover that off in the work programme, so promise we'll cover that where we go for our next steps. So, item 1, minutes of the last meeting held on 20th February 2024. Can I accept the minutes to record? Any amendments? No? All happy? Great, thank you very much. Item number 2, apologies for absence. Catherine.
Chairman, we have apologies from Councillor Carr and from Sarah Collis, the manager of Health Watch.
Great, thank you very much. Noted. I think everyone else is here, aren't we? Good. Thank you very much. Declaration of interest, number 3. Do any members present have any disclosed opinion of interest? I should say, do any members not? It'll be easier, but let's go on. Stefan?
It's been security staff here.
Thank you.
My father has a lung disease, IPF,
okay.
And I met with Action for Pulmonary Fibrosis in Parliament at the end of last year with regards to their integrated pathways, so I want to be transparent with regards to that.
Thank you, Michelle. Appreciate it. Thank you.
Chair, my daughter's trained to be a nurse.
Very much. Any other declarations? No? Okay, thank you very much. Let's go on to substantive agenda already. So, we're on item 4, which is lung health in Nottinghamshire. So, first of all, I'd like to welcome Simon Castle and Katie Lee from the Integrated Care Board, and Jane Roberts is here from Public Health Commissioning, and Viv Roberts as well. So, thank you very much. So, going to run straight into the item. I think let's crack on. So, straight over to Simon and Katie. Welcome.
Yeah, thank you. Thank you for inviting us here today to talk about the targeted lung health screening programme, which we've implemented across Nottinghamshire and Nottingham. So I'm Deputy Director for Cancer Diagnostics and End of Life for the ICB, and Katie, who does all of the actual project work. Katie?
Yeah. Morning everyone, my name is Katie. I'm the Project Manager for the Lung Health Check Programme in Nottingham and Nottinghamshire.
So next slide, please. So we just want to go through why lung health, in particular and lung cancer, is important to our health system and to the population that we serve. Katie's going to go through the model that we've implemented and continue to evolve throughout this project. I'm going to go into some of the results that we're now starting to see, which hopefully you'll see as a real positive. And then we're going to touch on our next steps for the programme in terms of evolution, how we're expanding across the whole of the system, and how this project will transform into the next cancer screening programme. So next slide. So why is this important, both nationally and to our system? So lung cancer is the third most common cancer in the UK, accounting for 13% of all new cancer cases. However, lung cancer is the most common cause of cancer death in the UK, accounting for 21% of all cancer deaths. So it has a significant impact nationally and locally. Lung cancer survival has not shown much improvement in the last 50 years in the UK and has fallen behind other cancers, and I'll come on to that in the presentation. And that's largely because of late presentation and diagnosis. That's a key factor in the poor survival rates that we see. And lung cancer also has a big impact on our health inequalities. 72% of lung cancer cases in the UK are caused by smoking, and there's a clear correlation between deprivation, smoking, and lung cancer. So therefore, our system has a significantly higher incidence of lung cancer than the national average, and that has a big impact on our health inequalities. And there's just some stats there on the next two slides about how the impact of deprivation, and this slide touches on that, how deprivation has an impact on increased cases of lung cancer nationally and locally. So as you can see, as you move up the deprivation quintiles, this shows the additional cancers, lung cancers that occur nationally and locally through deprivation. So you can see that as you move through the quintiles, we see a significant increase in lung cancer cases for males and females. So deprivation, smoking, and incidence are very closely linked. Next slide, please. This is a really important slide because it shows the percentage of cancers that are being diagnosed at an early stage. So good outcomes, good survival depend on early diagnosis. So we're looking for as many cancers as possible to be diagnosed at stage 1 and stage 2. and the national ambition is to achieve 75% of cancers diagnosed at an early stage. And this diagram plots for the East Midlands, and it's very similar position for Nottingham for each of the main cancers where they sit on that early diagnosis chart. So you've got incidence going on the y-axis going up, and then early cancer stage going across the bottom. And you can see that lung really stands out in terms of high incidence, but really poor levels of early diagnosis. And we want to shift all of those points as far as possible across to the right of the diagram. But you can see that for some cancers, and particularly lung, there's a long way to go. So we need to do something different. What's happening at the minute isn't really working. We need something that's where we go and actually go and find the cancers if possible at an early stage, and that's what this programme is about. Next slide. And then this just shows almost what's a league table for male and females in terms of 1, 5 and 10 year survival rates for the 10 most common cancers. So higher up the chart is better survival statistics. And as you can see for males and females, lung is right down at the bottom in terms of those survival charts. Next slide. And then this just comes on to the point I made earlier. This looks at the improvements in survival between early 1970s and going through into 2010, 2011. This is looking at 10-year survival and the progression that's happened for tumour sites. And again, you can see pretty much down at the bottom, very small progress in terms of lung cancer, in terms of the improvement in survival, falling behind many or most of the other cancers that are in place here. So it's a significant issue. And the final slide on this, kind of looking at the data, this shows the relationship for Nottingham County, relationship between stage and survival. So the red looks at the proportion that's diagnosed at an early stage and the 1 year survival. And you can see that the vast majority of cancers in Nottingham County are staged at level 3 and level 4, but where we have the poorer survival rates. As for example, a stage 4 cancer, you're looking at mean survival of 100 days. So it really is important we get these cancers early, and this diagram shows that if we can get stage 1 and stage 2, we can get good survival rates. Next slide. And just the impact this is having on our system overall. This looks at 1 year survival rates for the whole of our system, both Nottingham and City and County. It plots all of the systems and then looks at how we're matching against the national average. And you can see that for our system, we have been moving away from the national average. And next slide shows that the vast majority of that is in lung cancer. And that's causing a major impact on our overall lung cancer survival rates. And you'll see, hopefully in red, where our system sits on lung cancer survival. It's right down at the bottom end of that first graph on the left. So in summary, this project is about achieving much earlier diagnosis of lung cancer and other lung diseases, which then lead us to better treatment options and improved survival rates. So that's a bit of the context and kind of why this is important. I'm going to hand over to Katie now, who's going to talk through the model that we've implemented within our system.
Thanks, Simon. So we have two projects live in our system at the moment. So we have one in Mansfield and Ashfield, which was our phase 1 project. It was the first project that went live in April 2021. It has an estimated eligible population of 27,000. The eligible criteria for the programme is patients aged between 55 to 74 who have ever smoked. So that's past and current smokers. So we was looking at a cohort of 27,000 patients in that area. A bit about Mansfield and Ashfield. It's an ex-mining community. It's geographically spread over quite a large area. It has a high percentage of English spoken as its first language. And as I mentioned, that all went live in April 2021. We have expanded the programme into Nottingham City, which we call our phase 2. It's got a similar size eligible population to Mansfield and Ashfield. It has a high smoking prevalence. It's a bit different in that it's a city location, so it's more urban, it's closer together. Locations closer together, and it's very diverse in Nottingham City. Lots of different languages spoken, which we thought about when we was thinking about our comms and engagement strategy, and that one went live in December 2022. when these two projects were launched, they were launched as projects, so they both have an end date, and we're due to finish the cohort in Mansfield and Ashfield in March 2025 and Nottingham City in November 2026. Thank you. And this model here just shows what our lung health check pathway looks like. So we start by sending invitation letters out to patients, and we take a proactive approach in that we contact the patients. We don't wait for them to phone us, we phone them and ask them if they would go through our telephone assessment. And that's the first part of the pathway. So we do a telephone assessment with the patient on the telephone, and we go through some questions such as family history of cancer, smoking history, and all of their responses will build up a risk score. If the patients are low risk on that risk score, that will be the end of the pathway for them. But if they are high risk, they will be invited for a face-to-face lung health check, and that will be with a nurse on a mobile unit. We try to do the face-to-face lung health check within 4 weeks of the telephone appointment, so we really want people to stick with the pathway. So on that face-to-face lung health check, like I said, it's with a nurse. They will review the risk score and they will do the referral there for the CT. That's the opportunity for the patients to ask any questions to the nurse and for the nurse to explain the benefits and risks of having that CT scan. We also have a referral for the local smoking cessation service on the unit. So where possible, we try and have an advisor on the unit on the day that can see the patients. However, if not, we can do a telephone referral as well. So once the patient's been to see the nurse, they will then go and see the radiologist and have their CT scan on the same day. After the images have been taken, they go through an AI software called Adence on the graph there. So that's a new software that we use for lung cancer screening, and it's to support the radiologists with their reporting. It helps to speed up the reporting process because this is high volume. We've got lots of scans to be reported. After it's gone through the AI read, it goes to Heart and Lung Health, who are our specialist lung health check reporting body. They turn those reports around really quickly, so they work to about 72 hours to get those reports done from the scan, which really supports us in achieving our outcome, which is that patients receive an outcome letter within 4 weeks of that scan. After the scan's been reported, there are different pathways that patients might go down. So if there is a scan that has a suspected lung cancer finding, we have a fast track into either Sherwood Forest or NUH for those patients so that they can be seen as soon as possible. We also have a pathway into screening review meetings, which have been established at both hospitals for any other incidental findings or any other cancer findings that have been found when we've done that CT of the chest. At the moment, we don't send any incidental findings to primary care. That's quite a conscious decision. We wanted to make sure that it was all managed in the screening review meeting at the hospital, and was conscious of the workload there in adding to the primary care workload. Thank you. Next slide, please. And here's some pictures of our mobile units. So they are essentially two lorry trailers. The first trailer is a mobile clinic unit, and that has 3 clinic rooms in there, 2 for the nurses and 1 for the smoking cessation advisor if they're present on the unit. It is self-contained, so it has toilet facilities, staff kitchen facilities, and that's ideal because we wanted that. We run a service 7 days a week, 8 till 8 p.m, so we wanted it to be self-contained so we can put this anywhere. We're not relying on public toilets to be open and things like that. And then the second trailer is the CT scanner. So that helps us to achieve that one-stop shop service that we was looking for. So the patients can go and see the nurse and go and have their CT scan on the same day. And we site these lorries out into the community just to try and make it really accessible. We wanted to reduce any barriers for people participating, and that's been really well received by people coming. They haven't got to travel, they haven't got to go to hospital for their scan, they can come and have it in a convenient community location. Thank you. Next slide, please. And this slide here just shows the sort of process that we go through in choosing those locations. So we'll look at an area. So I think this one is Sutton in Ashfield area. This is more Mansfield and Ashfield as a whole area, but yeah, this is how we map out where we should site the unit. So we look at the GP practices, we look at the big supermarkets that are in that area. It doesn't have to be supermarkets. We have used leisure centres, we've used council buildings, we've actually also used the car park here as well. And then once we've got an idea of where those big supermarkets are, we also look at public transport routes. So on the map, it might look like an ideal location, but also want to make sure that those public transports do stop at those stops so that it's really accessible for people to attend. Thank you. Next slide, please. I'm just going to pass over to my colleagues to discuss the smoking cessation slide.
The smoking cessation service. So ABL Health Limited currently provide smoking cessation support as part of an integrated wellbeing service, Your Health Knots. And this is a 12-week quit programme which follows NICE guidance and provides both behavioural support and also nicotine replacement products and or e-cigarettes as a quit aid. So ABL Your Health Knots have been providing a stop smoking service to targeted lung health check programmes in the county. So that includes so far phase 1 in Mansfield and Ashfield, and also the targeted health lung check programme in Mount Bassetlaw. And then they'll also be providing a service in the forthcoming phase 4 of the programme, which is going to be in Mid Knots and also South Knots. Just to give you an idea of the number of people who've actually quit smoking through the targeted lung health check programme. So in Mansfield and Ashfield, we've got 234 clients who've quit smoking, and in Bassetlaw, we've had 123 clients who've quit smoking. And I know that ABL Your Health Knots are very keen to make sure that respiratory nurses on the unit are able to have a very brief conversation with smokers to try and emphasise the positive benefits of giving up smoking, to potentially increase the number of clients who are actually willing to take up the offer of stop smoking support, because obviously we want these current smokers to actually quit smoking, and the targeted health lung check programme is a golden opportunity to try and persuade people to actually quit smoking.
Thanks, Jane. Next slide, please. So now I'm just going to talk a little bit about the communication engagement strategy that we do with the lung health checks. So to get the outcomes that we want from the programme, we need to make sure that people are attending. So we do a lot of work just to try and increase that uptake rate. Next slide, please. So starting with the engagement work that we do, we'll go out to lots of different places and just try and spread the word about the programme and distribute some of our comms engagement materials. So that starts with some of the GP surgeries that we'll be visiting. We look at pharmacies. We link in with the resident development officers and also the social prescribers or link workers if they've got them in them areas. We also link in with community groups and any faith centres, any voluntary sector organisations that are working in that area. So we do a big scoping exercise to map this out and see where we can try and spread the word that this is coming to that area prior to us arriving, and those invites going out to their patients in that area. Next slide, please. So here's some images of our patient information. So we have an appointment letter that the patients will get initially. As I said, that's a letter that says that we are going to phone you for your lung health check appointment. There's no requirement for the patient to phone in to book an appointment. That letter comes with an information booklet which explains a bit about the lung health checks and the benefits of attending. And we also have a dedicated programme website. And on there we have some quite powerful patient stories on there, and also an animation video which explains what happens during the lung health checks. We've recently had a plugin installed on that website as well, so it can now be translated into lots of different languages, the entire website. We've got materials on the website as well that have been translated into lots of different languages. We also have functionality on the website for people to email the booking team if they wish to change their appointments, which has been well used. Thank you. So I mentioned that we use supermarket car parks a lot as our sites. They are good locations. It provides a lot of visibility when these units are in a big supermarket car park. And we try and link in with the community champions from the supermarkets, who tend to be really helpful people who can help us to promote, not only to use their car park, but also to promote inside the supermarket as well. So we do things like put posters up, leaflets on the tobacco counters where we're going to find our eligible population, and just do some promotion works actually inside the supermarkets prior to us going to that site. Next slide, please. Thank you. We also do public transport advertising. So in Mansfield and Ashfield, that was largely bus advertising. In Nottingham City, we also extended that to tram advertising as well. Next slide, please. And these are all our assets and promotional items. So we have flyers which we hand out to all of those community groups that I mentioned on the first slide. We have posters. We all have those translated into lots of different languages. And we have some promotional items which we use when we go out to engagement events. So again, that's something we'll scope out ahead of going to a different location. Are there any events going on, especially those that are health focused, and we'll try and get a stall so that we can have that visibility at those events prior to us going and sending out the invitations. I think this is the last slide on the comms and engagement, but perhaps the best comms and engagement tool that we use in the programme, and that's the targeted social media campaign. It's relatively cheap and it has a large reach. So we've got some stats there of one of the campaigns that we have run. It was a week period, and it was specific to a certain area, so we can be postcode specific. And this particular ad reached 4,345 people for £300 spend. So it's quite a good tool, definitely for the money, good value for money there. And we can monitor the reactions, we can respond to comments, and also we can monitor the clicks through to our website as well from that, because we'll put that on that page. Thank you. Back over to you, Sam.
Yeah, so now looking at some of the results and the outcomes that have been seen both at a national and local level. So this is a national slide which has been replicated locally, which is looking at the impact of the programme on the early diagnosis rates for lung cancer. You can see the large drop there in the middle of the graph, which was COVID. COVID had a significant impact on early diagnosis rates for lung cancer. But then you can see that recovering and then really accelerating forward as the targeted lung health check programme really started to be implemented across the country. And you can see that significant climb in the early diagnosis rates on the graph, and that's continued to climb as the programme expands nationally. So a real positive there on the impact. More importantly, this is the same slide, but looking at, again, deprivation quintiles. And the dark black line is the most deprived quintile, and you can see that before COVID, during COVID, the most deprived had the lowest early diagnosis rates. But you can see since the programme has been implemented, the black line now is actually the highest quintile in terms of the early diagnosis rate. So we've seen an absolute shift in terms of the early diagnosis rates for the most deprived areas of our population. So a real positive. Next slide, please. And then just some more detailed analysis of what's happened locally, specifically for Mansfield and Ashfield. So as Katie said, a really high uptake rate. We're really pleased with this. And that's down to we think the comms and engagement, but also the community locations that we've delivered this from. People are constantly telling us that it's so easy to access. It only takes 20 minutes maximum from when they arrive to leaving the vehicles. And the patient experience has been fantastic. Over 10,000 scans now. As Katie said, we've completed the first round of scanning in Mansfield and Ashfield, and we're now going back round to locations to start the 24-month scans. We've had over 100 lung cancers diagnosed, and I think actually that's a bit out of date now. It's even higher. So 103 lung cancers, but we've also picked up 17 other cancers because of where we're scanning. So that would be breast, kidney cancers, and some lower GI, so other cancers as well. And as mentioned before, and those are the slides, 65% early stage diagnosis rate. So that's doubling what we're seeing in symptomatic patients who present normally through their GPs or through emergency admissions. So we've doubled that early stage diagnosis rate. And even higher is the treatment intent, which is 68% curative versus 38% palliative, because that's even some of the later stage cancers, the stage 3s, we're picking those up very early, which is allowing for patients to have curative treatment. So that's even more positive. But we're also finding significant amounts of other incidental findings, and I'll come on to a slide in a moment which details that. But there's just some of the numbers which I've at an early stage, which was the whole aim of the project. Next slide. A bit hard to see, but this just shows how we're looking into this data in a very detailed way. So we look at the total number of cancers being detected, and that's the first slide in the top left-hand corner. This is for Mansfield and Ashfield, and you can see when those blue dots start appearing, that's when our programme started in Mansfield, and that graph is showing that there's been a significant difference in the number of cancers that have been diagnosed. So that demonstrates that we're pulling cancers forward earlier and diagnosing those. And then you can also see a corresponding drop in the stage 4 cancers going down, and the opposite with the stage 1 cancers going up. And the kind of bottom middle slide shows in total the stage 1 and 2 cancers, and you can see that we've gone from below the mean to above the mean as the programme has expanded. So hopefully that demonstrates that this absolutely is having an impact in total cancers diagnosed and at an earlier stage. Next slide. And then, as mentioned, because of where we're scanning, we're also finding there's significant amounts of what we call other incidental findings. So heart disease, other lung disease, some of it related to the mining community. We've also found liver lesions, etc. So, and these are just the what we call the significant findings which require action. So you can see quite significant numbers in terms of heart disease, significant respiratory and other lung disease. And as I mentioned, that there'll be some of the categories there include some of the mining conditions that we'd expect to pick up in the communities that we're targeting. And these are all being actioned and patients managed through the appropriate pathways and services. So although this is largely about lung cancer, it is picking up, as I say, lots of other diseases which, if we're picking up early, again, will have a positive impact on health inequalities. Next slide. So in terms of next steps, so we're going to our next phase. We should be starting in May, and that's back into Mid-Knot. So we'll be doing the Sherwood part of Newark and Sherwood. And that will take a year, and then we'll be coming back into south of the county, into Hucknall, Arnold and Calverton in 25-26. And our aim is to screen the whole of the population by April 2027. Bassetlaw is also undertaking a programme as we speak, and that's served by the South Yorkshire programme, because Bassetlaw patients feed into Doncaster and then have their treatment in Sheffield. But just to reassure you that Bassetlaw is part of this national programme, and indeed they should be finishing their first cycle of scanning at the end of this financial year, and they've had equally good results and good progress. And the table there just shows the data that we use to kind of prioritise where we go in terms of geographies. So we look at current smoking rates or ever smoking rates and the percentage of lung cancer mortality. So it's not just some random selection of populations. We use very targeted data to identify where are the priority areas that we need to go through. And that's very similar to all the screening programs that have been implemented. We can't go, for want of a better phrase, big bang and screen the whole of the population all at once. We have to go in a kind of targeted, phased approach. But as I say, our ambition is to do the whole of the population by April 2027. And this is then leading on to an announcement last year that this programme now will become the next national cancer screening programme. So following from bowel, breast screening and cervical screening, lung will be the fourth national screening programme. That's estimated that will start somewhere around 28-29. So just as we're finishing our 100% population, this will transfer into the next national screening programme. The data is that compelling that the national screening programme have felt that yes, this needs to be the next programme, which is a real positive. And we've made an excellent start in progressing that. Next slide, I think that may be it. So conscious we've probably bombarded with lots of facts and figures, so any questions?
Okay, well, thank you very much for the report, and obviously for the presentation. There was one slide that came in late that wasn't our packs, but actually having that information beforehand, I think, gives everyone a really good opportunity to be able to go through and help prep for scrutiny stage. So we appreciate that. And I mean, just for our recommendations here today for the report are to consider and comment on the information provided and to look at any further consideration that we may want to give to the item and how we look at that in future. So, I mean, I think it's quite, when I went through it, and I've done a bit of work around with No Smoking Day, obviously this month with a Never Had to Have at Rushborough Council being cabinet member there for health, and obviously looking at some work there, it's really telling in terms of the link between smoking, absolutely, and lung cancer there, which might seem obvious, but actually when you look at the data, it's frightening, isn't it, really, for want of a better phrase, and looking at the work you're doing there and the impact that's had so far in the areas you have done, I think just shows how really important it is to detect it early, as you showed there. And again, it might be easy enough to say that, but I suppose that's a message I personally like that goes out there, is that you should never be afraid to go get yourself checked, and that doesn't matter what condition it might be, because you can just see with the data, the earlier you get diagnosed, the better. I know that from my own family as well. I'm sure everyone else has their own stories, but I think that's a really important message to go out there, which is what you're showing in your results today. And I suppose the 75% uptake rate is, for me, is that compared to national average thing elsewhere good, or actually to me that does sound quite good on the face of it in terms of an uptake on any scheme. I don't know if that's just across things I'm used to anyway, but what's your thoughts on that?
No, we're pretty much the highest in the country,
Okay.
and that's been replayed back to us in terms of praise, and other programmes are very keen to understand how we've achieved that. As I say, I think that's because of the excellent comms and engagement, which is very targeted, but also the community approach in terms of delivery of the service is, we're absolutely clear. Some projects have tried to run this through the hospitals, and they've not had, as you maybe expect, the same engagement and uptake. People have told us that they wouldn't have engaged with the programme if it had been at the hospital, but it's because it's in their local supermarket. It's convinced them to attend. So we're convinced that's the approach that should be produced, and we're trying to take some of that learning back into some of the other screening programs. For example, breast screening. So we're trying to get breast screening to increase the amount of local scanning that they do, because the vast majority of that is in hospitals. So I think there's learning from this program to take to other programs as well. So no, we're right up there. We're pleased to say we're right up at the top in terms of the uptake.
Thank you very much. So I'll bring in Councillor Eddie for this one question.
Thank you so much for the presentation. I represent Warsop in Mansfield, so one of the proper ex-mining communities. And I know the MP for Mansfield and the MP for Sherwood did a lot about the lung screening tests in Parliament. I know they've raised it quite a few times. I suppose one of my questions leading on from Councillor Wheeler is the 75% uptake. What are we doing to get the other 25%? And then, is there any chance, so with the ex-mining communities, we know there's loads of other lung conditions that they get. Is it just for smokers, or is there something that's going to move forward? When you say 100% of the population, do you mean everybody, or just the people who have smoked? Just, because I know in communities like the one I represent, there are, conditions that are related to the mining community.
I'll pick the second one up first, if I may, and then maybe hand over to Katie. So it's not 100% of the population; it's 100% of the targeted population. So the evidence states that the two primary causes of lung cancer are age and then smoking history. Now, through the actual assessment, other information is taken about working in industry, mining, etc., exposure to asbestos. That will influence the risk score, but in terms of being invited, it's purely based on age and whether you've ever smoked, and that's based on research. Huge trials in America, Europe, and England have identified the main risk factors. But as I say, once they're invited, questions will be asked about their working history, and that can change their risk score from low to high. So hopefully that's answered there. But it's constantly being reviewed. The data is constantly being reviewed and refined to see what factors are at play here. But at the minute, it's age and smoking history are the two main incidents. And then hand over to Katie for the first part.
Yeah, in terms of the uptake, so 75% is a really, really positive uptake, but we never settle with that. We always looking to see if we can improve it further. So we will look at areas, we'll look at on a GP basis, if there's any GPs that are lower than we would like, and we can maybe do some targeted work with that GP or in that area. We do things like we've also offered now paid for transport. So although we have this in the community, we've offered that as an additional, if transport is a real barrier for you, we can actually pay for taxis to get you there as well. So yeah, we do continually work with the practices with the lower uptake rate to try and increase it.
Just to add, we look at protected characteristics of the patients who are not attending to see if there's anything happening in terms of age, sex, ethnicity, just to even further target our competent engagement. So yeah, we're trying to get that as high as possible. So just to give assurances, we're not kind of patting ourselves on our back and saying that's great. It's the higher the engagement rate, the more effective this program is. So we're constantly trying to learn to see how we can improve that rate.
Thank you. Michelle.
Hi, thank you for your presentation. Could I just ask a question to start before I say anything, just to make sure what I'm saying is correct? When you talk about phase 1 and phase 2, it then jumps to phase 4 in here. What is phase 3? And the other question is, when you talk about phase 1 being Mansfield and Ashfield, and then phase 4 being Sherwood, are those district council boundaries? What are those, or are they constituency boundaries? So when you talk about Mansfield and Ashfield, is that the whole of Mansfield as in what the MP covers, or is it what the council covers? Because it gets quite different in that end of not. So before I say anything, I just want to be clear on what the next 2 phases are, where they are and where they will be covering before I speak, if that's okay, Chair.
Just the one on the first bit about the phasing, on the phase 4, that should be phase 3 on that slide.
It's confusing because nationally it's counted as, it's gone in stages, and nationally it's a stage 4, but for us locally it's a stage 3. So that's just, it's confusing for us sometimes. Yeah, we're just trying to test you, and congratulations, you picked it up, you passed. But it's nationally it's a stage 4, but for us it's a stage 3. So Mansfield, Ashfield, Nottingham City, then we're going to Sherwood, then we'll go to, as we say, Calverton, Hucknall, then we'll probably go back to Newark to complete Mid-Knots, and then back to the remainder of the South County.
So in the Sherwood bit, for example, this is my question, is that what is covered by what? What is Sherwood to you as to what areas they are covering? Because Sherwood to us might be the parliamentary constituents, but Newark and Sherwood covers a bit of Sherwood, and Ashfield covers a bit of Sherwood, and there's a bit in Mansfield that's covered by somebody else. So it's really important that we understand where are those people living for the next phase, and where are those people that are living.
So we tend
now,
to go.
I'm sorry to be awkward about it.
So we tend to go on the health boundaries and go based by the GP practices and where the populations are resident in terms of the GP practices, because we invite populations by GP practice. So sometimes it doesn't quite fit and align with some of the boundaries you're describing, but that's how we tend to invite populations, is based on, because we pull off the patient records via the GP systems. So that's the common way to do it, to not create any confusion. But it can create confusion, as you described.
To speak now, Chair. Okay. Thank you for that, because I was somewhat confused. So the first thing what I want to say is thank you for coming in and doing a presentation with actually so much detail in it. I think that's really important, and we do appreciate it when you come here, and for spending the time when I know you'll be very, very busy people. I welcome the fact that you're looking at that next phase, and you're considering those levels of deprivation. For us here in Nottinghamshire, and I make no apologies for consistently saying this, the health inequalities that still exist in Nottinghamshire, the 7.5 years difference between those that live in the south of the county to the north of the county, is something that we really need to continue to get a grip on here in Nottinghamshire. And some of that is by the work that you are doing is absolutely essential, because you are marrying up levels of deprivation, and that. So I really, really welcome that. I also welcome the work that you're doing around lung cancer. So I've got a few questions and a point that I'm going to make. My question is, from diagnosis to seeing a consultant for someone in lung cancer, what is the waiting time at the moment for that? Because that is going to affect stage 1, stage 2, stage 3 and stage 4. So I'd be really interested to know what that is in our hospitals. And then the other thing that I want to mention is with regards to what triggers, who will get those letters with regards to scans. So I've made it quite clear at the beginning that I've had conversations with Action for Pulmonary Fibrosis, and their latest, what they talk about is when they've interviewed people that have this lung disease, and this is no reflection, and it sounds really bad what I'm going to say, but it is their official campaign, and I don't want it to be disparaging to anybody that has lung cancer, but what they feel is that lung cancer gets a lot of support and they don't. And if anybody has seen anyone that suffers from CWP, black lung, anyone that's seen anyone suffer from IPF, I mean, it's horrendous, and anyone that suffers from COPD, to see how they suffer and what happens to them as a person, and the isolation and the mental health and everything that it creates around that person, I find it really difficult to read when you say that actually, especially in the communities that Councillor Eddie's pointed out, where there is still the industrial diseases, and I don't believe it's just mining as well. We had a Players factory here where young people were put in smoke rooms full of smoke and then given a pint of milk after they finished their shift to cool down their lungs. You know, these are elderly people that are still living in our communities. So it is people working now, but there's a whole industrial problem. To have the diagnosis to have the thing where it says age and smoking, with those people that I've spoken to that have got CWP, IPF and COPD, which I know you will know are horrendous diseases with no cure. There is no cure. Once you all get that, that's it. I find it really hard that it is just on age and smoking, because all of those people that I have spoken to, not one of them would have received necessarily a letter from yourself to be scanned. When you do go to the doctors with a lung disease, the wait for a CT scan is months and months and months and months. And then the diagnosis for going to see a consultant is even longer than that. When you get the treatment, especially at your age, it is absolutely brilliant. There are names that I can mention that have been absolutely fantastic. But my worry and concern is that the lung cancer work that you're doing is obviously been really, really beneficial. But there are people in Nottinghamshire enduring some of the worst diseases in this country, and we don't talk about it enough, and we don't look at how we're going to support them more. So my question is, how can we as a county council do more to help those people that have got those lung diseases, and what can we do? Is there a way that we can integrate a NHS pathway with what you're doing for those other people that suffer those other lung diseases that could quite possibly, such as, have you ever worked down the pit? Have you ever been exposed to asbestos? And then the other question is, and this is quite pertinent, I think, because of the other thing that I've spoken to, and I've spoken to people with regards to NHS England, that at what point do we ask the question whether someone's had COVID as well, to the extreme? Because a lot of people that are coming through with regards to IPF now, there is a strong association of actually being hospitalised from COVID as well. And so those are my questions. I have declared that I have an interest because I have an interest in what the Action for Pulmonary Fibrosis do, and I'm an advocate for their integrated pathway, and I would ask that, you know, ICB, whoever it is, goes away, looks at that pathway and makes every effort to establish a pathway for those lung diseases other than lung cancer, where people across Nottinghamshire are suffering the most horrendous diseases, and I am watching my dad suffer from it, and I would not wish it on anybody in the world. So it's not necessarily, it's too late for my dad, but all those other people that live in Nottinghamshire, we can create a pathway for them that gives them the treatments. They don't have to suffer like he is suffering.
Sure.
What a difference that would make. Thank you.
I mean, like I say, we're specifically here to talk about the lung cancer programme, and that's what we were asked to implement nationally, and we said we wanted to be one of the first to do it. So I understand the issues you're talking about, other respiratory diseases, but this programme was specifically about lung cancer, and therefore the risk factors that lead to lung cancer are age and smoking history. There's very little evidence to say that other factors are significant. So now, as we've shown in terms of findings, we're picking up a lot of other respiratory disease, and then people are being fast-tracked through to spirometry. Heart disease, they're having echo tests. So although the headlines is cancer, I can assure you, as the graph shows, we're picking up lots of other disease. But in terms of them being invited, it has to be based on evidence base, which is age and smoking history. Otherwise, we'd flood the programme with very low-risk patients who it would mean the service isn't applicable. So I think you're making a valid point, but it's separate to this programme. So that's probably not giving you the answer that you want, but in terms of this programme, they're the criteria that we have to stick with.
Can I just so
But yeah, my colleagues are probably even more versed than I am in terms of other issues of respiratory disease.
So thank you. So first of all, thank you for sharing your experience there. I appreciate that would be a really difficult situation to work through, and I can really see your passion in this area. I think just building on what Simon was saying there, I think first of all, it's a great opportunity for Nottinghamshire that we've been able to be a front runner and a pilot in this. And I think, thank you to the work of Simon and Katie and the ICB team in terms of really pushing the boundaries on some of that work around health inequalities, and that we really want to be strengthening across Nottinghamshire. So thank you for that. Just in response to some of the points that you were making, the councillor, I think there's something to be really think around in terms of when we're looking at screening programs. There's really strict criteria in terms of what can be put in a screening program and what can't. Because with any screening program, there's a balance to be had in terms of inviting people to have a screening process, which is not a diagnostic test; it is a screen. In terms of there are always opportunities that there might be false positives and false negatives. So I think when Simon's talking about really going back to what that evidence base is, that's where some of that rationale has come from, that in terms of making sure that the people that are being seen are the people that do have potential first or second or third stage lung cancer, and we want to make sure that we see them as quickly as possible, but equally that we don't put people through processes that maybe they didn't need to go through. So I think the evidence base is incredibly important around that. Having said that, I think there is something around, there's a wealth of information that Simon and the team are collecting, and I think it's really important that we understand what that means for us in Nottinghamshire specifically, acknowledging that our communities are different and we need to respond to those specific needs of our communities, and I'm sure the ICB will be looking at how they are continuing to learn through that. But we can think around how we feed back, and I'm sure Simon and the team will do that through that evaluation. Because this is a new screening programme and it's seen some excellent results. That doesn't mean that has to, that we can't learn and grow from that moving forward. So, I'll be very supportive with Simon and the team in terms of how we can support from a public health basis, but just wanted to say, it's a great start, but let's continue to learn and grow from this and think around what that means for us in Nottinghamshire, acknowledging that, there is limitations in terms of this specific programme as it's sitting now. So thank you for that.
I asked what the
There was a waiting time.
Yeah, the waiting times.
So the aim is from diagnosis to treatment is 31 days is the national standard. Clearly, you'll have seen that a number of targets are challenging because of post-COVID, the backlogs that we've had to face, and some of the impacts of industrial action. But those performance rates are improving, and so the latest figures were up at around 80-85% of patients are being treated within 31 days. We're very acutely aware that any delay in treatment potentially has an impact on stage and outcomes. So we work very closely with the trust to keep within that 31 days. Any additional month delay potentially has a big factor, particularly those patients who are on the edge of being a stage 2, stage 3, they can what's called stage shift. So we're really keen to limit that as much as possible. And hopefully the data shows that because we're getting 65% early diagnosis rate, that's being successful. We've put additional capacity in to all of the pathway, the lung cancer pathway, from the scanning through to the diagnostics. We've put additional treatment capacity in place, particularly theatre capacity, because most of these patients are now having surgery. And so we've put additional theatre sessions in, additional surgeon is in place at NUH, predicting the additional work that was coming. So we've tried to match the capacity with the demand coming through, and at the moment we're achieving that.
Yeah, just a point to you then, Chair, really. When I asked for this in October, I was quite clear that I wanted it to look at all lung diseases, and did mention the fact of CWP and COPD and IPF with regards to their pathways to care. So can I suggest that we've had them today, can we bring that back as a matter of urgency with regards to the pathways, with regards to diagnosis and treatment for those patients living here in Nottinghamshire?
I think what's really important is just to get as much information as we can from ICB colleagues on the work being done. So I'll get that circulated as soon as we get back to matter of urgency, and then we can review absolutely how we best go forward. So I'll look into obviously what happened there. Obviously, the measures before us on the committee, so I'll look into any confusion that was potentially caused to bring the item here today. But I think what's really important is the points you've raised are important to people. I completely get what you're saying as well. Your programme, what it's targeted at. So I think it's important we need to look from both sides to make sure we are getting that information out there for council. We can scrutinise that as well. So we will absolutely take that back and work at that as well. So I appreciate you're only here for that particular programme, but we will look at that separately as well. So thank you. John.
Thank you very much, Chair. Can I say thank you for your presentation? Excellent. A bit startling, some of the information in it, because I didn't know much about it. But the first thing I'd like to talk about is your engagement, that you've said you've got a whole list of GP surgeries, pharmacies, community groups and churches, care homes, and so forth. Well, I go to approximately, in 12 months, 89 different organisations, including Carers Association, Breathe Easy, COPD, talks, doctor surgeries, community group, and many community groups. But I've never seen any of your information being at the doctor surgeries or any other places. I must be missing something. I really haven't seen anything at all. So, and that's in Hucknall, which is statistically.
We haven't. Yeah, so we haven't. So in fact, we haven't been to Hucknall yet. The programme hasn't started in Hucknall, so that won't start until next year, maybe the end of this year. So Hucknall is going back to phases. It's going to be phase 4. So once we've done Sherwood within Mansfield National, then we'll be going to Hucknall, Calverton, and Gedling, is it, or Arnold? Arnold. Yeah. So
you've never ever done anything in Hucknall?
Not yet, no, because the screening isn't there yet. But if you relay that commentary back to us and you're still not seeing it when we're there, then we'd be really concerned and we'd like to know and do something about it. But I can assure you that we absolutely go into the surgeries when we're going into a specific location. So as we're doing now in Sherwood, we're going into all of the agencies that you described.
Well, the reason I'm saying that, I do see other information about other cancers and so forth, and get in touch with this group and this organisation, the hospital and so forth.
Yes.
But I've never seen anything at all about.
I can assure you, when it comes to Hucknall, you'll be seeing plenty of advertising in terms of different groups.
Yeah, thanks for that. Anyway, can I firstly say that I fully support that this council's plan for a smoke-free Nottinghamshire by 2035, and the attempts by the government to take people away from smoking and to stop people actually starting. It's all very welcome, but I wonder if anybody agrees with me. However, the fact that Nottinghamshire Pension Fund still invest in tobacco companies does that fly in the face?
John, I completely get what you're asking at that point. I know it's a question at full council, but you can imagine the colleagues here can't answer that question, and I hope you can appreciate that. So
Yeah.
I know that's being asked at full council, and we'll make sure you get the answer will be covered there. Okay.
Well, my next question, of course, is if lung cancer is the third most common cancer in Britain and the most common cause of cancer deaths, accounting for 21% of all cancer deaths, and shown no improvement in survival rates in the past 50 years, why have more resources not been pumped into this issue, at an earlier date? Because if something is the worst possible or the third worst possible situation, I just wondered why it hasn't been.
It's a fair challenge. Some of that is due to technology that there hasn't been. The evidence has shown that screening programs up until now would not have worked in lung cancer. One of the main differences is we now have what's called this low dose CT scanning, which reduces the risk of the CT in terms of consequences, because with any intervention, any scanning, there are risks to the population, and so that's quite a bit of a game changer, is this low dose CT. So we're giving the population having the scans very low levels of radiation. I think it's similar to a transatlantic flight to America, whereas before that technology wasn't in place. So it comes back to what colleagues said about the risks and the benefits of any intervention, any screening program. And up until now, it was felt that the risks were too great in terms of some of the particularly the screening. So part of it is due to the technology that we now have. We can have these low dose CTs in a van, in a car park, and that's a real game changer. But to some degree, you're also correct that lung just hasn't had the publicity, hasn't had the focus within the NHS up to now. It has been, as you know, breast screening, but partly some of that is due to the evidence as well. I don't know if colleagues want to add anything more on that. Oh.
Thank you. So absolutely acknowledge what Councillor Wellmark's saying and how Simon's responding to that in terms of from an NHS response. I think what I would say though is from a public health point of view, there has been a significant amount done around tobacco control and really taking it back to that preventative approach, because we know that 2/3 of smokers will die with a smoking related disease. So actually what we really want to do here is ideally stop people from taking up smoking in the beginning, and there's a significant amount of work being done around that to develop our smoke-free generation. But if people have started smoking, it's about how we can support them as early as possible to quit smoking and really have those benefits from quitting smoking as early as possible. So I think, when Simon's talking a lot around once people have had those risk factors and once they're starting to see that in the first stage 1 or 2, 3 or 4 of the lung cancer disease, but ideally we don't want people to get there at all. So I think there is something around really thinking around that preventative lens and really acknowledging that a significant amount of work has been going on in Nottinghamshire and nationally around smoking generally, and continues to do that, and we will be increasing our accessibility to our ABL smoking services. There's significant more investment going into smoking this year and over the next few years, so please be assured that it's an absolute priority in terms of getting to that smoke-free generation for Nottinghamshire, and we will continue to do everything we can to achieve that. Thank you.
Yeah, I just wanted to come back in and say that it's not so much the treatment or lack of treatment that's the cause of the poor outcomes and the mortality. It's largely the late presentation and late diagnosis, and that's because there's partly a view that lung cancer has poor outcomes. It's the perception of the public that lung cancer is diagnosed late and therefore the outcomes are really poor. But what this demonstrates is if we do get it early, the outcomes can be as good as many of the other cancers. So it's not so much if that makes sense, it's not so much the lack of diagnostics or the treatment. If we get patients early, the outcomes can be as good as other cancers. It's about that early diagnosis. And up until now, patients tend to present to their GP late, which makes it very difficult in terms of the treatment options. It tends to be palliative. So what we're trying to do is bring it forward. Obviously, the best method is prevention, But if that's not happening, then it's earlier diagnosis. And up until the perception of the public is, oh, lung cancer, I see my friends, it's stage 4, it's not particularly pleasant. I almost don't want to know, I don't want to present. And it's about changing that kind of mindset of, if we get it early, it can be very positive.
And do you agree with me that it seems that living further south you are in Britain, in England, the better survival rate, according to the statistics? I wondered what your thoughts are on that one.
Yeah, I mean, it's harder for me to look at a whole population like that. I mean, we have differences in Nottingham in terms of outcomes, so it's sometimes not as easy just to break it down to a north-south divide in the country. Even in Nottingham and Nottinghamshire, we have differences in survival rates, so it's a little bit more complicated than purely a north-south. But again, if my colleagues want to comment, but yeah, that's not my expertise in terms of.
Thank you. So we know that some of the key risk factors for lung cancer and a range of factors that lead to lung cancer is due to deprivation. So one of the things that that you might be seeing some of that is the links to deprivation, and we know that there is that north-south divide in terms of some of our deprivation. So I think there's something to really consider around that, but there is also things to consider around what can we do in Nottinghamshire, because Simon is absolutely right. There are significant health inequalities in Nottinghamshire, and how can we make sure that we're addressing this? And I think the programme that has been presented today is a really good example of how we are tackling that. And I think the graph that Simon showed earlier around how actually our most deprived population have got the highest rate of early diagnosis is a real significant achievement of this programme, because that is not something that we would normally see in screening programmes. We tend to see our most deprived population are less likely to access for a range of reasons, and therefore they do tend to get diagnosed later in those later stages, and then they have poorer outcomes. So some of that will be linked into that. So I think it's going back to, there's some really positive outcomes coming out here, and I'm really keen to work with Simon and the team in terms of how we then really share some of the learning, because I think some of the engagement and very local engagement that has done here has really secured that buy-in from our community, and I would imagine accessed a lot of our population that may not have accessed in normal and traditional ways. So some great learning, and yeah, it'd be great to think about how we build and strengthen that moving forward.
My final couple of questions is the introduction. You're offering e-cigarettes can be part of a package of interventions. That's what you're saying, and yet many doctors are saying that's not the answer. I just wondered what your thoughts on that, and who do we believe in that area? And it's good to see the introduction of a new local expansion plan for screening, especially in my town of Hucknall, which again statistically is proving to be the worst area, and it just seems that Hucknall has the most lung cancer mortality rates. Overall, Chairman, it's sad that not more has been done earlier to combat this serious issue of lung cancer, and the fact that this is the first briefing that we've ever had. It's not good news, especially as the lung cancer is the third most mortality rates of all cancers. So if you just answer that question about the e-cigarettes, so you go to one doctor and he says, it's a good thing to go on to, and another one says, no, it isn't.
Yes, absolutely. On the spot.
So thank you very much for the question. So e-cigarettes have a very good evidence base to be an excellent quit aid for smoking. And I think we are very clear that the evidence is very, very strong in terms of supporting people to move from cigarettes and tobacco products onto a safer product in terms of an e-cigarette. Having said that, we also don't know the very, very long-term effects of e-cigarettes, and that the evidence is still evolving around that. We do know that the harm created by e-cigarettes is significantly lower than cigarettes. So the evidence is already quite strong in that area. What I would say, though, is that we wouldn't encourage people to start vaping or using e-cigarettes when they wouldn't normally do so. So I think there's something around the messaging around e-cigarettes are an excellent quit aid, but we wouldn't want him to be encouraging people to start that up if they weren't going to do that necessarily. But I'm going to hand over to James if there's anything else that you wanted to add on that. If that's okay.
Just wanted to share the Nottinghamshire Health and Wellbeing Board's position statement in terms of e-cigarettes. So Nottinghamshire Health and Wellbeing Board supports the safe and regulated use of e-cigarettes as a choice of a route out of smoking for adults without becoming a route into smoking for young people and non-smokers. So it's very much a balanced approach.
Yeah, it's a good point to Rachel on to talk about there, but it's really important about the communication, and I think it's also what's really important, the point you raised about, in particular, like Hucknall having a high mortality rate, is to say that the screening is great, but people shouldn't wait for that screening. If they need to go to the doctor, they'll just still absolutely go to the doctor. In the first second, the screening is I'd say an extra bonus on top, but absolutely shouldn't just wait around for that screening to start if you feel like you may potentially be at higher risk of cancer or have the symptoms. Please to encourage everyone still. I think that's a message we need to get out from across the whole community, is to still please go to the GP and your doctor as soon as you can if you believe you've got the symptoms, because as we've already been proven, the earlier you go to get checked out, the higher the chance of survival and recovery. So thanks for those questions, John. Thank you, colleagues, for answering. So next I've got Nigel and then David after that.
Thank you. Thanks for the presentation. The word Nottinghamshire, or the term Nottinghamshire, has been used quite a lot. Guess where I'm from? I'm from Bassetlaw. I'm from Worksop, born and bred. Notts lad and proud of it. Great lung cancer programme. If I'm stopped by a resident in Bassetlaw and asked a question about lung cancer, where do I go?
So this exact programme is live in Bassetlaw as we speak, so it's part of the South Yorkshire programme.
Exactly the same.
Which has been exactly the same. So and Katie is in close connection with the people who run that programme. So that's been in South Yorkshire in terms of Barnsley, Doncaster and Bassetlaw in the past year. So again, mobile screening going into locations, and then patients are fast-tracked into pathways that go into South Yorkshire, so it'll be Bassetlaw, Doncaster, and then into Sheffield as their treatment. But exactly the same pathway as part of this national programme. But Katie, you're in close contact with colleagues there. We talk to them and learn from them from all of the programmes that are local to us. So give you that assurance. We don't manage that programme, but it is part of the national programme.
So how do I access that information?
We can put you in touch with the people running that programme, so either the South Yorkshire Cancer Alliance or even the local project manager, Katie's equivalent. We have their details, and they've done similar presentations in terms of their uptake and their outcomes, so I'm sure they'll be willing to share that.
I remember sat in chamber a couple of years ago in another meeting and we were talking about strengthening the links between
Yes, I'm more than happy to liaise with Simon and Katie to get information in respect of what's been happening in Bassetlaw on the programme, and get that circulated to all committee members as well. The programme, I believe, is due to finish its phase at the end of this month, so there may be a slight delay while they sort of evaluate their findings. But I'll through Katie and Simon, I'll get that information to you.
I think it's quite important as well in the area of Bassetlaw, which we're talking about mining communities, and at least 5 pits that I can remember in Bassetlaw. So
I think you're right, Nigel. I'm going to bring Katie to me, but when we got that briefing note sent through by Noel about the programme in Yorkshire, to me, what Striker was saying the end of March, and Noel said there, so it's thought we can. With the plan in my head was discussing today was to say let's get to the end of March and contact South Yorkshire to say now you've finished that, can we have that data so we can analyse it and decide if we want anything extra here as well. So it's a really good point to raise because the way the boundaries run, obviously we want to make sure that Basel doesn't get missed out, because sometimes again it's not being covered by yourselves and colleagues there. So it's really important to us to make sure all our Nottinghamshire is covered, make sure there's some quality, because we've had other programmes that come before where it's shown that we don't feel that's been the same equality, so we just want to make sure that's happening. So that's why I asked the question. It's right that Nigel and can keep asking that, rightly so. So thank you. So Simon or Casey, do you want to come in on the last point?
Yeah, and just to give assurances, we work very closely with the South Yorkshire Cancer Alliance. So we're in the East Midlands because of the geographies, but we work very closely with South Yorkshire and learn on a number of cancer projects, including lung cancer screening and targeted lung health check. So we make sure that all of the populations are covered.
Yeah, if I can just add to that, historically, Basset Law was always in the South Yorkshire region, same as Yorkshire Ambulance Service and EMAS. That's you know that. So we've always historically in this committee had that debate in here because a lot of the stuff was happening in Nottinghamshire but wasn't happening back or happening at a different pace in Basset Law. But yeah, that changed when we invented the Integrated Care Board. That's why they brought Basset Law back in. I'm sure I'm right there onto it. That's why it was brought back in, and it's still some of the stuff is still on a different tangent. Anyway, that's that. Well, thank you very much for your presentation. It was filled with a complex myriad of information, and I'm sure that's only the fringe of what you see, which is really good news. And I think it is a good news story, especially, I mean, it's targeted by the NHS latently, we might add, but they've got there in the end. And I think that is because there are a lot of other peripheral illnesses that Councillor Walsh was talking about, some of them. There are a lot of other peripheral illnesses related to smoking that have never been correlated together in the past. And it's only over the last decade or so that correlation has come through, and that's why we've now got the screening process as it is. Because obviously smoking illnesses affect social mobility and all that goes with it. I mean, I've got, not in my family but in my wife's family, one with methicillemia, and then another one with lung cancer. They were 51 and 61, and they've been gone 20 years, and that's sad. So anything that we can do to redress that balance is great, and the 68% curative as opposed to 38% palliative is also good news for the screening programme. But of course, as well, it's not just that. It's like you're only touching on the fringe of the fact that you're picking up all these other things as well, and that can only be a good thing. And obviously, Nottinghamshire must be in a good place because we're running that screening programme ahead of the national one, which is really good, isn't it? So we've got a real good foot in the door there. So I'm sorry, I didn't say I'm county councillor for Selston, so I'm smack in the middle of phase one, and I saw all the posters and the screening busters in the car park. I saw everything. Yeah, I did. I was even screened myself, so I know. I actually know what you're doing, and it was in the doctor's surgeries. It was in the co-op. It was the buses were out there, and it was really good. And of course, it has to be in Ashfield and Mansfield because I remember, I've been on this committee about 9 years, and I remember seeing month after quarter after quarter after quarter, female pregnant mothers' highest smoking rate in the county is Ashfield and Mansfield, and it's shocking, that is really. And like in answer to John's question about e-fags, yeah, they're designed to get people who smoke onto something less harmful. But we're seeing a trend now. We're seeing a trend now of younger people who are taking them up because they're trendy, and that's why we did something earlier last year, I think it was, on adult health and social care about the marketability of e-fags, because I'm sure we're going to see a tsunami in the next decade of issues related to e-fags. But I hope it doesn't happen because they are supposed to be less harmful. But anyway, that's enough about e-fags. But one of the things you talk about, your promotional route has been a lot better than other areas, and you've been praised for that, and good, because I've been on this committee, like I say, nearly 10 years, and NHS posters for advertising things have always been totally flat and boring. They don't incite me in any way whatsoever. You know what I mean? They are always too much information and a little picture that looked like it was drawn by Tom and Jerry's sidekick, and I think we need to really do something about that. If I was going to say anything about it, because you're talking about a market age of people who are a bit younger than me, so in their late 30s, early 40s, nearly 50s, that kind of, and they need something to engage them. And NHS posters are the most boring things I've ever seen, I'd sooner look at the fish tank with the dentist than that. They are. Honestly, they're the most boring thing I've ever seen. And so I think if you were going to try and engage with the public more, that would be one of the things that we do. And I always remember with cigarette packets, what they did with cigarette packets was they used to start putting a picture of somebody's cancer-ridden lung on the side, and it's something that grabs people's attention because they're paying. I think I don't know. I packed up smoking when I was 28. So that's a long time ago. There must be about £10 a pack now, and that money is obviously still not putting them off. So government keep putting tax upon them for me because smoking is one of the worst things, and all the illnesses that are associated with it are just so debilitating on human life and the quality of life as well. And actually, when we talk about lifespans, the difference between Bassetlaw and Rushcliffe is about 10 years, and 4 of that is definitely attributed to smoking. We know that, and the other one probably, they're just a small mixture of things. But that would be my ask, if you could get your comms team to actually do something that engages people, and actually sharing it with the county councillors here would be a good thing, because there's about 66 of us, not to be too precise. And we could share that information out, but I'm not going to share your NHS posters because I don't like them, obviously. Thank you.
Thanks for the yeah. Well, thanks for your kind comments about the programme and reassuring that you did see the comms material. We recognised very early on that we needed a broad breadth of kind of comms and engagement material, and we didn't want to just do the typical posters and flyers. So we've put a lot into the website, into videos, a huge amount of engaging in local WhatsApp and Facebook groups and using videos on there. So posters and leaflets have a place, and we try and make them as exciting, but we can make them as interesting as possible. We try to put patient stories in there and pictures of some of our patients. So Bill has been one of our assets in terms of trying to make that real and authentic. But leaflets and posters are not going to be the way to do this. It's got to be much more targeted in our approach, and I think that's what's been successful. But really keen to work with you to get advice and feedback on our comms material, and we can share those. And if any suggestions to make them better, then we'll take them on board. We have a dedicated comms and engagement person who works pretty much full time on this. That's how important we've seen the comms and engagement, but we welcome feedback.
I was just going to say, we do have a QR code on the poster. If you click that, you can go through the animation video, which is a bit more interesting than a poster.
Yeah.
I thought you were Mike. You mentioned that social media is quite a cost efficient way of, and I've got a good experience of that over the last 20 years, and it is a great way of getting your message across, and quite as you say, a relative cheap way of doing it as well. I would like to see more, because I mean, as you rightly say, there's 66 of us here, and we can get that message out. It's not difficult to cut and paste or even just share.
Mike.
Yeah. So back to that, the flat poster. I've got to go on a QR code. I wouldn't do that. I'm sorry, but I just wouldn't. I wouldn't sit there at home thinking, "Oh, I've got to get my phone out on my phone and get a QR code." I just wouldn't do it. So a flat poster is going to get probably 100 clicks, but a video, that's a different thing. A video will probably get you 3,000. So I think animated video would be the best way to go, and lead the way with it, because you're already leading the way with the program. So you've got to show the others how to do it, because you could compound the effectiveness of it by changing little things like that.
Thank you, Chair. Yeah, thanks for all the brilliant work you do. Anyway, and making people aware about smoking. I actually do smoke, but I'm a bit old now to change, I think. And getting back to getting back to getting back to your e-fags, Simon. Getting back to your e-fags, though, a lot of people when they change to them, and I've found them as well, they make you cough more, and that's the truth. And that's with a number of smokers I know. But anyway, that's me.
You don't take one in the first place.
Yeah, well, yeah, good idea, David. But anyway, just a quick one. When you look through the chart, I'm guessing that Beeston, Stapleford, Trowell and all that, we must be phase 3 because there's not actually a breakdown of any of the areas. Because getting back to what John said, I haven't seen a screening programme in Broxtowe Central. So I'm guessing, Simon, Katie, we must be West Nottingham, 26, 27.
Yeah, I mean, we're trying to accelerate that earlier if we can, and we are ahead of the game. We are ahead of our trajectory at the minute, so we'll be starting in coming back to Hucknall and other areas. We're trying to accelerate that. So if we get that into 25, 26, we'll try, but it will be 26, 27.
Thank you. May I suggest probably the tram stop as one place to put the mobile scanning unit? And just a question on, unless I'm hearing it wrong, you've got to be a smoker, so obviously I'll get a letter.
No, so it's called any smoker. So if you've ever smoked, I mean, we're actually doing open invites as well. So that the first targeted invitation is to the age category and ever smoked, but we're also inviting the whole population as well, just in case the smoking status recording on GP systems isn't accurate, and sometimes it's not. So we do cover the whole population just in case the smoking status isn't right. So everyone in that age group will get an invite of some kind, but we target the ever smokers first, if that makes sense.
Because Simon, round the Area Wash in particular,
yeah,
as a lot of people have mentioned in different industries,
yeah,
obviously was a lot of forge, there was standing iron works, a lot of asbestos there, and I've known quite a few people who's got asbestos, what do you call it, asbestos, now, who are that type of age, and this probably, and were smokers actually, some of the gentlemen I know, and ladies, but it would have helped them, and he's the last few years. But on that as well, do we think about going in? I mean, the biggest employer actually in Broxtowe, off the top of my head, is the post office now, right? I'm on about Broxtowe. I'm sure it probably is Nottinghamshire, along with Boots. Do we go into workplaces as well? Do we invite them to these screenings in the areas?
We certainly engage in those areas in terms of comms and engagement. So we can work with you to go into specific large employers and work with them in terms of the comms and engagement. The invites will come through via the GP practice that they're resident with. But certainly we can go into large businesses or large employers and work with them in terms of spreading the message and getting them to accept their invite.
Chair, just that's what I'm saying, Simon. That's what I'm saying, because most men and women don't like going to the doctors, probably don't like admitting that they do smoke, even though I have, right, or anything else. So perhaps just to make, because it's without being rude, it's that macho thing. Oh, there's no wrong with me.
Yeah.
And I worked on the railway. We always had as medicals. I found working at the post office now, they don't give you a medical.
Sure.
They used to, yeah, Michelle. But now it's just the big employers, so they're aware. It might not be in their area, Simon, at the time.
Good point. Yeah.
You know what I mean? But just to make them aware that they can go and get screened.
Yeah, that's a good point. And we're keen to work with you when we come to your area to do that.
So just on that point we said about the open letter that goes out. So after you've done the first letter, people have smoked, and I understand why, because some people may never told their GP they smoked. What's actually in that other letter? Because that's the only point we've raised about people who, potentially ex-minors or other lung conditions. Would they not be able to come as part of the second? Would they not be targeted part of that second open letter or not? Will it? Sorry.
No, on the opening letter it will say, I have you ever been a smoker? Are you in this age category? If so, you may be eligible for a lung health check. So it's not quite the same approach that we take for the people that we know to be the eligible population. It's a bit less intrusive in that it's just an open invitation letter for them to phone if they think they're eligible, but it wouldn't include those other conditions.
Okay, thanks. We'll come back to that in the end. So that's great. Thank you. And so, Mike.
Thank you. Just a few bits again. Thank you for the presentation. Just to check, because everybody else is, so I'm going to hop on the same bus. The Arnold checking stuff that you've mentioned, does that cover the whole of Gedling Borough, or is that just Arnold? Because although some people believe Arnold is the only place in Gedling Borough, I'm talking about the whole of Gedling Borough itself, including all the villages, Burton Joyce, Carlick, Woodborough, Lamley, Carlton, Ravenshead. Do we know if it's what that covers? Because I didn't see that again in the list. I'm just wondering.
I have to come back to you. I can't remember the exact boundaries, but we can come back to you outside of the meeting actually to give you clarity.
Great.
Using that.
Thank you. And just a couple of other things. I mean, I think QRs are great. I mean, how you log into your smart telly to watch catch-up TV without QR, I have no idea. So it's something that we definitely, it's definitely more widely used and it is helpful. Something else that sort of occurred to me. I mean, I used to start smoking when I was 14. Used to spend a part of my dinner money instead of spending on food to buy 10 of a certain brand. And obviously, looking back on that now, I mean, you realise that you're obviously substituting something quite terrible for food. But obviously, they're even cheaper then, and they're now substantially more expensive. We're talking about inequalities in terms of levels of smoking in certain areas and things like that. Do we drive the cost aspect as well with the programme? Specifically, I'm thinking about, me substituting that dinner money to buy cigarettes. Again, I wonder, in terms of the knock-on effects for health, the wider health, because people are substituting what they need to be doing rather than for something that they have to do because they're addicted to it. And I just wonder is that tracked through the process? Is the data gathering to understand how people fund that habit and subsequently what damaging effects that's having outside of just the pure illness you can get from smoking? I was lucky enough to get on the New Leaf programme and had the Champix, which were the weirdest experience arguably in my life, but they stopped me smoking. So I just wonder what that is and how that comes about, and if we're tracking that, and if so, because that leads further down to, we're talking about issues of health, and if people aren't eating properly because they're substituting for something else, again, we're talking damaging other parts of health as well, and malnutrition arguably in younger people, because if it's the adults that are using it to fund their habits, then again that money isn't getting to the children as well.
I mean, certainly as far as I'm aware, through locally or nationally, that isn't being looked at through this programme. I don't know if there's any local intelligence or data, but not specifically through this programme, no. I mean, smoking cessation is a key component, and we're trying to maximise the quit rates, but I don't think there's any analysis going on at the level you're describing.
So I think there's something slightly. I'm just trying to separate, I suppose, what's the lung cancer programme and then what we've got in terms of our stop smoking and our offer there. Now we know that smoking is very complex and that there is an addiction element to this, and therefore it is complex and it is difficult for many people to stop smoking. Certainly as part of that approach and the service that we deliver or we commission through ABL, there's a significant element around motivational interviewing and a lot of discussions around really understanding what are the particular motivators for that individual. Because for some people it may be because they've had a particular trigger point in their life. They may have gone and had that attended their lung cancer screening and that was a trigger. They may have had a really difficult bereavement or case within their family. For other people it may be actually they're really struggling to not only feed themselves and their children, but heat their homes or have that broader agenda around having a good overall health and well-being. So I think it's just to reassure you that there's a lot of discussion and that's very tailored to the individual as they access the service. And we do regular needs assessments around understanding where we are in Nottinghamshire in terms of our smoking prevalence, what are our drivers, and what our new evidence is around that. But Jane, I didn't know whether you know anything specifically around the data collection on that.
I think you made a really good point in terms of the kind of impact of smoking, because the total cost of smoking is much greater than the kind of individual cost to individuals, because there's the health and social care costs, there's days off work through sickness because of smoking related illnesses, there's the environmental health cost as well. So when we think about smoking, we do need to think about the impact of smoking and the kind of total cost of smoking. It costs this country billions of pounds a year in terms of like I say, both the days off sick, the health and social care costs and environmental costs, as well as the cost to individual people in terms of their health, and also how much they're spending on cigarettes. The other thing that we're trying to do in the county is tackle illegal tobacco and illegal vapes, because of course some people do actually find the cost of buying cigarettes from a normal kind of shop exorbitant in terms of expense. So there is illegal tobacco available. So we're actually working with trading standards in the county to try and tackle illegal tobacco and also illegal vapes. And we're also trying to tackle underage sales in terms of children and young people.
No, that's great. I'm glad to hear that, and I think the vape thing is key. I watched a documentary about that, and they were saying like the levels of aluminium in illegal vapes, and effectively that they're inhaling aluminium directly into their systems, which causes all sorts of horrible things to happen to your body. So that's really good that you're working with trading standards on that. And just a slight wider point, for me, the financial cost was huge, because if I hadn't have quit, I couldn't have started my business, because I couldn't afford to have done it, because the first few months it was very difficult to get along in a new business, and that cost of smoking would have prevented that from happening. So I think there's also a question of social mobility as well in terms of that, and how that's potentially restricting people in terms of their ability to get on in life as well, because that money's being invested there, whereas maybe they'd have the opportunity to do something else with that money that would lead them to better, longer life outcomes as well. So yeah, I think just if in any way possible, where it can be, in any of the work that we do as far as the NHS is concerned, and getting the negative aspects of that. Maybe, I don't know whether you do any sort of mentoring program for people as well, and showing them good cases of people after smoking and how. I haven't seen much of that. I've seen how destructive it can be to your lungs and the pictures of that and all that sort of stuff, but I don't know how much post-smoking stuff we've seen, and about how the positive outcomes can happen as well. But I think that's quite important for people, because they need to see the light at the end of the tunnel. There was a great graph that you do that talks about what happens after 10 minutes, what happens after half an hour, 40 minutes a day, 20 years, 10, whatever. And I always found that a really nice thing to follow as I was going through the quitting process. So I think it's just showing those end results and the positivity of what can happen at the end of it as well, because it can be a real preventer of positive development, I think, in people's lives. So good on you for doing the work, and good on you for the fantastic efforts to try and detect the issues that it causes, because it's a nasty habit and a very destructive thing for, as we've heard in the room, for many people's lives. So thank you very much.
Thanks, Mike. I think it's something that we can take away comments and short with the committee about what more we can do to push out the work, the various organisations out there. I know from the work I did at Rushcliffe in terms of the various like smoke-free knots, etc. There's a lot of groups out there, free advice as well as obviously potentially paid advice as well. And I think what's really important is anyone watches this meeting who does want to potentially go out smoking, especially having Mike here today, is to seek that advice. And there's plenty of support you can get on websites, and with a quick, I wouldn't say Google, kind of think I'm allowed to, limits like the BBC or not, but there are other search engines available, of course, to go and then have a look. But no, thank you for that, Mike. I mean, look at the report. I mean, like I say, from what we heard today, we've really covered this in a lot of detail, and really appreciate all colleagues' involvement, and of course, here for answering it. We come back to the point that Michelle raised, which is really important, was, and this is not because I know you've been sent here to do this is not in no way directed at yourselves, was that we did ask for overall lung health. So that's something we'll go back and take up with ICB colleagues to ask that. We did expect this in addition, because as we just rightly said, lung health, absolutely, what you're doing is fantastic work there. That's part of the puzzle, and it's the other one we need to make sure it's all joined up thinking. So we'll absolutely get in contact with those colleagues at ICB and look at how we can get some information out, hopefully sooner rather than later to colleagues initially. Then we can look at how we analyse that, scrutinise that going forwards. So that we are proposing we add that into the recommendation, just so that's down on record, so to speak, and we'll take that away going forward. I think for me, look at the programme we've done. I mean, just what you touched on, Mike, would be important if you can bring back that breakdown of geographical areas, because as Michelle said, there is so many Sherwood councils. I mean, there's Sherwood in the city, for example, there's Sherwood council-wise. Sherwood means so many different things to different people, and we talk about Genning as well, the boundaries. When someone sits in the electoral commission, I don't think they realise what the impact it actually has on the description of people else. So it's really important if we can, just so we can make sure, again, we can put that to our colleagues, so all councils can, again, reinforce your message around comms to say, please make sure you are participating. And open record as well as being some Rushcliffe as well, to say that although it's lower mortality rate, obviously the fact with that one the highest rate of former smokers, which again surprised me when I read the statistics, where you could see the statistics there. I think it'd be really important just understanding what the programme is going to be like, we're looking at the future again. Since it borders Clifton, some people may be seeing when we've gone to Morrison at Clifton and seen them and go, oh, that might be coming to me soon. So we can communicate that to my colleagues as well as myself and Rushcliffe. So to go back to recommendations, consider and comment on the information provided, which we've done in great depth. Thank you there. Where it's scheduled further consideration is necessary. What I want to add to that is that we will speak to the ICB, communicate the ICB to request extra information on other areas of lung health programmes that have been delivered in Nottinghamshire, as well as this programme there. We'll then look to get that information cascaded out to members who get that back, and then happy at the next meeting we discuss way forward about scrutiny from there, if the information in time. Would that be accepted to everyone? Michelle, is that okay?
Yeah, can I just ask, we usually Health Watch usually is here.
Yes, Sarah gave her apologies.
Yeah.
Oh, yeah.
And I think they always give us a really good insight into the patient experience. And I would be really interested going forward when we're looking at lung diseases, because of how it affects people emotionally, the isolation and the mental health issues, that we have someone that does represent those people that are suffering from lung diseases, and that we, as a health scrutiny committee, hear from their experience of the pathways as well. I think that's really important and is really, really helpful to us. So I'd like you to consider that if we go forward with this lung disease problem, that we have that representation. And I'm not sure that Health Watch, and in addition to Health Watch, I think with regards to this would be really useful.
Yes, and Sarah. I mean, no, Sarah, she's probably watching online or work back. I know she's also that's why she's not here, but I will have a chat with Sarah and pass that on and see what we can get information there as well. Because like you say, as much information as possible is, you can never have too much information, can you? Which are probably famous last words, but I think that's absolutely the right thing there. So if everyone's happy with that, can I put the recommendations to the vote? All those in favour? Okay, thank you very much. And I mean, Simon, thank you very much for your time today. I know it's a long session there, and please pass on to your colleagues who are part of the programme as well, especially on the front there. We do appreciate the work being done there, and I think there's a good bit of learning to take away in terms of the community engagement. That's something that we're doing at County Council a lot in terms of, as people know, there in terms of work around especially family hubs, etc. I think there's a really good piece of work, especially for the rest of the ICB and NHS as well, about that way forwards to make sure we get that engagement. So it's really interesting. Thank you overall for that. Thanks for your time. Thank you. Right then, so on to the final substantive item, which is the work programme. So as I mentioned at the start about Newark Hospital, that has a change to the work programme I'd like to propose. So I spoke to our colleagues at the ICB before the meeting in terms of they've evaluated for April, and they are happy to come along and to obviously present to the committee based on the briefings we've seen yesterday around the decision they've made around the opening hours of the Urgent Treatment Centre. I think it's important, given the public scrutiny and the amount of work that the committee has done so far on it, that we do bring it back at the first available opportunity, just to effectively scrutinise the decision process so we get as much information public domain as possible. Because I think what those who were on the briefing saw, and when I was speaking to colleagues there, was there's a lot of information there, rationale behind that is important. That's in the public domain for then people to make their own mind up and decisions from there. So my proposal would be that we bring that forward 16th of April. So we bring that to the 16th of April meeting. The wait time to elective surgery, I'm proposing at the moment we've looked to potentially move that to May, just because my feeling is that item could be quite a long one and quite detailed. Maybe wrong. Again, the other we might have cursed now, be 20 minutes, but based on the previous discussions, I'm just really important that it's such important. They're both such important items. I don't want us to get to a point where I know other members have to leave after need for other meetings, etc., and we don't give it proper scrutiny. So again, there may be something else that comes through that may have to be sorted at short notice. So if with your discretion, we'll look to provision with that to May. Maybe we may have to move that around depending on what items come forward. And then going forward, May, Nottingham Healthcare Trust. I mean, again, as I mentioned last meeting, it's really important that we go through the recent CQC inspection and scrutinise that work being done, because there's a lot of concerns being raised about, in that sector. I think it's really important we get colleagues here from the Healthcare Trust to explain that in more detail, what they're doing to both address those concerns and reassure the public. June, as mentioned before, I've asked the NUH to come along and give an update on the maternity service provision. I'm going to be meeting with Donna before that meeting as well, separately. So, and then hopefully get a bit more information about what's again being done locally in terms of the update on her review. And I would just say on the NUH as well, I did meet with a representative of NUH ahead of their recent board meeting regarding to the work we've done there. So I think it's really good news in terms of the progress being made there. And they recognise it's not the end of the line, and they absolutely know that. I think we all know there's still a lot of work still to do there, but encouraging to see the two sort of CQC flags being raised and the other red flags raised at the moment. And I know from speaking to the chief executive and to the director of comms there that they are committed to keep working out forward, especially with the recent board appointments, which I think will make a really good addition there. And then the June meeting as well would have the additional 1-1 service performance data that members requested at our January meeting. But at the moment, July, we've got the ICB policy alignment boards scheduled. So, any other questions on the work programmes, John?
Just when we can have a progress report on the health and wellbeing provision of the Capital Centre. It's a question that's been asked to me so much now. It's unbelievable. It's making my life a misery that this situation was brought up over a year ago now, and it's been talked about for 10 years, but it specifically been talked about over a year ago, and you still don't know what is happening. So could we have an ICB and NHS here to explain to us, to the Hucknall people, when this Capital Centre is going to happen?
Yeah, so John, I mean, I completely understand it's really most subject, especially in Hucknall where you represent. So at January, we obviously agreed to hold it until we got the revised proposals from the ICB NHS in terms of where they're going, because my understanding, and I'm sure the same as yours and everyone else here, is that there's been a pause in terms of the delivery of the centres while they're obviously looking for location and the funding. So what I can do is, if I go back to the colleagues at ICB to ask if there's an update they can share, and that might be one discussion of yourself, maybe a brief note to go out in the first instance, then we can look at from there if there's something from that information that we can take forward or not, because I think it's really important to the first still to know if that's been able to move forward or not, because again, I don't have the information either. So I'll go back to those colleagues and come back to you, John, so we can look at how it works. So, okay. Michelle?
There is an update and it is moving forward. I'm not sure who Councillor Wilmot's talking to with regards to that health centre in Hucknall, but it is moving forward. The last thing I just wanted to say, Councillor Wheeler, just to not keep people for too long, but just to thank you for the way that you've come into health scrutiny and the way you're doing it all along with Councillor Eddy, because actually I think you're giving us all a fair chance to speak, and you're respecting what we say on the work programme, and I wanted to just thank you for that, because actually it means a lot for me to be able to speak about the things that I've spoken about today, so on a personal level as well. So thank you for the work that you're doing. Thank you.
No, thank you for that, Michelle. I think what I said at the first meeting that stands now is we want to get everyone to have a fair opportunity to raise issues that are important to our residents. I mean, that's what we're here for to do. So please keep doing that. If there's issues that are coming up there to your communities that we can look to scrutinise, and we'll keep looking if it's something that we can scrutinise, we will do, or put it to the other committee. So I do appreciate that. So if we are happy with that as a work programme for now, then I will move that forward for that to vote there for the current work programme. All those in favour? That's carried. So thank you very much for your time today. I know it's been a long session now. I think it was really important we covered that. So thank you very much, and shall see you all in April. Thank you very much. And close recording. Thank you.